يعني ما تتفوتش كده يا دكتور. ده طلعت حاجه كبيره، ما تتاخدش كده خالص يعني. دلوقتي هتبتدي الدكتوره بسمه شحاته مسك الختام بقى، هنسمع الكيس برزنتيشن منها، ودايما بنسمع من الدكتوره بسمه احلى كلام يعني، فاحنا متشوقين نسمع.
مساء الخير. thank you. I'm very thankful ان انا اكون موجوده في وسطكم النهارده. هقدم case presentation بسرعه جدا عشان ميعاد الصلاه. هي female preterm 34 weeks gestational age, third order of birth of a positive consanguineous marriage. The mother was gravida 4 para 2 with a history of previous SIP death at day 8 of life in a neonatal intensive care unit. The mother had preeclampsia during pregnancy and was given 1 course of antenatal steroids. The patient was born by section due to decreased fetal kicks. She had a smooth transition with an upper score of 8 at 1 minute and 9 at 5 minutes, with no need for active resuscitation. She presented to our NICU on the second day of life with poor suckling. On presentation, her Apgar score was 36 weeks. She was active, jaundiced with the following vitals. Her temperature was 37 degrees Celsius, heart rate was 140 beats per minute, respiratory rate 43 breaths per minute, capillary fill time was 4 seconds, and the anterior fontanelle was at level. On examination, she was 1900 grams, just below the 50th centile when plotted on Fenton charts for girls. Occipitofrontal circumference was 31 centimeters, length was 44 centimeters. She had fair suckling with intact molar reflex. Chest, heart, abdomen were clinically free. Initial labs, they were all more or less normal with negative CRP. The CBC was fine with a total leukocyte count of 7.7, hemoglobin 14.7, and platelet count 309,000. PT and PTT were normal. Liver function tests were normal. Sodium, potassium were also normal. The point was the creatinine of the patient was 1.2 with BUN of 7. The total bilirubin was 13.1 with a direct bilirubin of 0.9. She also had an ABG of 7.33. Carbon dioxide was 22.9. BICARB was 14.7. Base excess was -13. The patient received phototherapy with adequate feeding using maternal own milk. General condition improved with no need for respiratory or inotropic support. Jaundice improved with the bilirubin level decreasing within 1 day to be 9.6 followed by 7.5. The creatinine improved, but in a slower rate to become 1 on the 3rd day of admission, and urinary output was around 3 to 4.5 ml per kg per hour. On the 6th day of admission, the patient became clinically dehydrated. She had diarrhea, which was mucoid with a frequency of 9 times per day. No associated fever or vomiting. The abdomen was lax, it wasn't distended, no napkin dermatitis. ABG with a pH of 7.11, carbon dioxide of 23, bicarb of 9. The patient was given shock therapy, repeated IV fluid bolus therapy, and inotropic support. Yet, the compensated metabolic acidosis didn't improve. The bicarb was persistently low, around 14 to 16 ml equivalent, even though the patient's general condition was much better. With no signs of dehydration and adequate urinary output. She was still passing stool from 9 to 12 bowel motions per day. Investigations done. We had lab investigations in the form of ammonia lactate and extended metabolic screening, and they were all normal. As regards the radiological investigations, we had a pelvic abdominal ultrasound, which showed gallbladder mud together with urinary bladder turbidities. Transcranial ultrasound was apparently normal with a slightly higher resistive index, and the echo showed PFO and tiny closing PDA. Urinary output never exceeded the 4.5 ml per kg per hour. The urine analysis was done and it was normal with the 5 pus cells, acidic clear sample, no hematuria or proteinuria, and the urine culture showed no growth. Again, the patient deteriorated with an attack of sepsis, generally deteriorated with enlargement of the liver and distended tender abdomen. Labs revealed a CRP of 71.4, CBC with a total leukocytic count 12.5, hemoglobin 11, and platelets fell up to 53,000. Creatinine was 1.3, and sodium and potassium were normal. The antibiotics were shifted to Miranem, Vanco, Amikine, which were renally adjusted, and Flagyl with addition of diflucan. Patient was kept MPO for a week. Strikingly, she kept passing frequent amount of mucoid stool, around 10 to 12 times per day. Well, on return of the oral feeding, we changed the formula to extensively hydrolyzed formula, and still no improvement of diarrhea, with a heroic purging rate of 150 ml per kg per day. The patient's lab and sepsis screen improved to become, the CRP improved to be 10.4, the total leukocytic count improved, and the platelets raised up to 272,000. The creatinine was 0.5. She still had diarrhea, and there was an accident when the vascular access was lost while the patient was on 110 ml per kg oral feeding. Still, she became severely dehydrated in spite of very good oral intake and no vomiting. The pH again was 7.1 and the BICARB was 9. So now we have a patient with intractable metabolic acidosis with a normal anion gap. Metabolic acidosis is defined as the accumulation of non-carbonic acid equivalents, which arises from excessive production or inadequate excretion of hydrogen ions, or from an increased loss of bicarb. Preterms are more susceptible to metabolic acidosis because they are more susceptible to conditions such as cold stress, infection, and respiratory distress syndrome. In addition, preterm have a reduced capacity to prevent and correct acidosis. As regards the renal system, although the kidneys will respond to an acid load in a qualitatively similar manner to a term, yet immaturity of the renal function results in reduced glomerular filtration rate, lower tubular bicarb threshold, and increased urinary sodium loss. As regards the pulmonary system, additionally, any concomitant respiratory disease may restrict the ability of the preterm infant to compensate for the metabolic acidosis by increasing the excretion of carbon dioxide. Metabolic acidosis, we have the following differential diagnosis. If we have an increased anion gap, we will search for acute renal failure, inborn errors of metabolism, lactic acidosis, or toxins. If we have a normal anion gap as our patient, we're thinking of renal bicarb loss as renal tubular acidosis or renal dysplasia, GI bicarb loss as diarrhea and small bowel drainage, dilutional acidosis, or hyperalimentation acidosis. Well, will we use the bicarb or not? Bicarb only provides an apparent improvement of the lab. The lab you're gonna get, it's much better. But still, there is no real correction of the underlying condition. It causes disturbed cerebral perfusion, and the patient's worsening may develop as a sequelae of bicarb usage in such conditions. The only warranted condition for bicarb replacement therapy is in the case of GI, renal loss, or in cases of inborn errors of metabolism. Thank you.
دكتورة بسمة، ميرسي على البرزنتيشن الجميلة، شكرا جزيلا. في حد عايز يسأل أي سؤال قبل ما نطلع علشان الصلاة؟
في دلوقتي صلاة يا شباب وبعدين البريك. أستاذ أحمد هيجايد يو ثرو الأوتيل إن شاء الله.